Hi everyone, we're just waiting for a few more to sign on, so we're going to get cracking in a sec. Just to give you a little bit of background, this webinar is obviously pitched at a variety of different practitioners. Some people are very familiar with Mobiderm, others won't have any idea about the product. So I've sort of tried to cover bits of all sorts to make it appropriate for you all. So we'll just give it a few more minutes and then I'm going to get going. Okay, we're looking pretty good. So, look, hi, welcome to the sixth, and this is the final webinar in this series. Today I'm presenting using Mobiderm in musculoskeletal trauma. My name is Janice Moore. I'm actually the owner of Moore Physiotherapy and Clinical Pilates, which is located at Upwey in the beautiful Dandenong Ranges on the outskirts of Melbourne here in Victoria. I've been a physio for over 20 years, and the majority of that time has been in private practice. And I have worked with various sporting clubs, including AFL and cricket. I've been an instructor for the Sports Medicine Australia Sports Trainers and DMA Clinical Pilates courses. Just a reminder, today's webinar is going to be recorded, so you will be able to reference it again. I will be taking questions at the end of the webinar. You can just write them in the chat section as you go. And we'd also like to direct you to the website, mobiderm.com.au, which has all the product guides, plus information on training and more case studies. Okay, I'm going to just go into give you a bit of a quick introduction into the companies that are actually offering this webinar today. Medical Rehab was established in Victoria, Australia in 2010. It is the sole distributor for the Mobiderm range in Australia and is committed to providing therapists and patients with not only high quality product solutions, but with ongoing support and education. Medical Rehab also stocks rehabilitation products, e-scooters, body sports and more. Thuasne is a French company that was founded in 1847 and is the manufacturer of the Mobiderm and Benoflex range. Every product is designed with close collaboration with those involved in the medical treatment of the patient and Thuasne. Thuasne creates and distributes medical devices that enable patients and consumers to become active players in their own health. Medical Rehab is proud to be the sole supplier of Thuasne's lymphology range here in Australia. So, why did I choose to present this webinar today? Well, think about that really nasty acute ankle injury that comes into your clinic that wants to return to sport now. Or that client who comes in with months or years of edema issues due to an injury and you're the fourth practitioner they've seen. What can you do differently? Well, I've got another weapon in my arsenal and I just wanted to share it with you. Like many of you, I've been frustrated with tubey grip and TEDS in terms of managing excessive or non-resolving edema in musculoskeletal trauma. It was out of a discussion with Jenny from Medical Rehab about Mobiderm products that the idea grew of exploring their effectiveness compared to my current management of musculoskeletal trauma edema. Since then, I've essentially played with the products and have personally found them to be fantastic at managing excessive or non-resolving edema, and even preventing an expected level of edema in situations it typically develops, like after total knee replacements. And I wish I knew about this product 20 years ago. Firstly, some background. Let's start with prevalence of injury. Ankle injury is one of the most main reported and researched sports-related injuries, along with hamstring, groin, and the knee. Soft tissue injuries account for a lot of lost playing hours and income. Better management could allow an earlier return to sport and less financial burden. Unfortunately, for you to best understand how Mobiderm will help, I'll give you a brief refresh on ligament and muscle physiology. Ligaments. Remember, they are not inert, but have a vast amount of vascular, neural, and intracellular communication. They are 2/3 water, and the majority of that final third is collagen, which is organised into crimp globules. Ligaments' initial response to load is to increase mass and stiffness, i.e. crimp collagen bundles start to creep or straighten until they straighten fully. With more loading, you start to get tearing of those bundles before complete failure of the ligament. We all know muscles produce movement by the contraction of long cylindrical cells known as myofibers. The nuclei of myofibers are terminally postitron, i.e. they can't divide anymore. So muscle regeneration, more so than hypertrophy, is dependent on other cells, like satellite cells, to occur. So unlike ligaments, there are complex vascular, neural, and intracellular communication just for the muscle to function, never mind to respond to injury or trauma. Both ligaments and muscles undergo 3 phases of tissue response to injury, but the timelines can blur into each other. Obviously, the injury occurs and there is bleeding. The first phase is the acute inflammatory phase, which continues for 48 to 72 hours. It is characterised by blood collecting in the area of injury, platelet communication with the various matrix components, and growth factors being released. From here end the proliferation or repair phase, which can last a few weeks. This phase is characterised by immune cells releasing growth factors to stimulate fibroblast proliferation to rebuild the tissue. The final phase is the remodelling phase, and this can take anywhere between weeks to years. Collagen maturation and rearrangement occurs to produce pre-injury style tissue. Please don't try and read this table now. Take a more in-depth look at it when you can access this webinar's recording, or look up this article directly at a later date if it's of interest to you. I've included it to remind you that there's a huge difference in cellular activity and the resultant organisation, strength and quality of tissue formed when a ligament is normal versus scarred. Again, this is another complex diagram that I encourage you to look at in more detail later. It demonstrates the cellular activity from proliferation phase through to myofiber growth in muscle regeneration from left to right. The top part is with acute inflammation, the bottom with chronic inflammation. Essentially, in normal acute inflammation, you get a lot of satellite cells, which are the purple ones, without the persistence of pro-inflammatory M1 macrophages, they're the green ones, which is the key to forming healthy myofibers. But in chronic inflammation, to the bottom part of the slide, you can see the lack of satellite cells and the persistence of the M1 macrophages and neutrophils, so fibrosis rather than myofibers are formed, and this will impair this muscle's function. RICE was the gold standard of acute injury management when I graduated, but more research is questioning how we manage acute injuries, so the acronyms keep changing. So RICE became PRICE with the adding of P for protecting, L for loading and O for optimal healing were thrown in the mix, so we had the police. Inflammation is now considered the enemy, inflammation is now not considered the enemy to healing, but as long as it's not excessive. So ICE and anti-inflammatory modalities in particular have more recently gone in our favour in the most recent research, as it is thought to interfere too much with desirable inflammation, so a new acronym has emerged. Last year, the British Journal of Sports Medicine flooded our social media feeds with this acronym, Peace and Love. Peace is for the first few days, P for protection, E for elevation, A for avoid anti-inflammatory modalities, i.e. ICE and non-steroid anti-inflammatory drugs, C for compression, but there are still conflicting studies, E for education. And after the first few days have passed, love, L for load, optimal load early to help remodelling as symptoms allow, O for optimism, being aware and active around the psychological factors, V for vascularisation, aerobic or cardiovascular activity as soon as symptoms allow, and E for exercise, play, the usual rehab and return to sport process. But there are more acronyms arising all the time. Look, David Pearce gave us unless on the APA Musculoskeletal Physio Association Facebook page just 2 weeks ago. So, why do I believe Mobiderm is the answer to these conflicting studies in acute injury management? Why is it better than TEDS or Tubigrip or not compressing at all? I believe the conflicting studies on the benefits of compression may be due to excessive compression being as detrimental as zero compression when trying to control edema. Mobiderm is a unique, complete care system for the treatment of all edema, not just lymphedema, as it actually stimulates the lymphatic system to do its job more efficiently. The name arises from mobilize, Mobi, dermis, derm. But remember that nasty acute ankle injury that comes into your clinic and wants to return to sport now? Or that client who comes in with months or years of edema due to an injury and you're the fourth practitioner that they've seen? Keep them in mind as I step you through what Mobiderm actually is. Mobiderm is an open cell foam cubes encasing essentially a hyperfix or fixamol style fabric stuck together. The cubes are typically positioned on their edge and in a random pattern, which is akin to the lymphatic vessels, which aren't all nicely aligned in straight lines under our skin. There is a layer placed under the Mobiderm to enable it to move on the skin, and a layer over the top of the Mobiderm to create the compression and hold it in place. Where the foam ends up the thickest, the highest level of pressure is created, versus where there is no foam, there is minimal or no pressure. This picture shows the anatomy of the skin, subcutaneous tissue, with the muscle lying underneath. The subcutaneous tissue contains the lymphatic vessels. The green arrows represent sources of pressure of the Mobiderm, which alongside the muscle underneath creates a shear effect to mobilize the skin. It creates a pressure differential, enabling movement of the fluid in the interstitial tissue from greater to lesser pressure. Don't forget, we have a lot of nociceptive nerve endings located in the skin. If the subcutaneous tissue isn't bogged down with edema and the skin can slide better and is not in constant tension, surely these nerve endings will become less reactive. So unlike most products, e.g. Tubigrip, that compress to cause reduction in filtration, Mobiderm stimulates the initial lymphatics, which improves the removal of lymph load while also reducing filtration. In a more in-depth look at the lymphatic system, we can see how Mobiderm works. The initial lymphatic vessel in Figure 1 is stimulated by the shear effect of the Mobiderm and draws in the surrounding fluid, as shown in Figure 2. This starts the peristaltic reaction in the collector lymph vessel in Figure 3, and the lymphagian stimulation as the system is loaded in Figure 4. I feel the best way to demonstrate the superiority of managing edema with Mobiderm is with case studies. Case 1 is not a client of mine, but I've spoken to them at length. This 50-year-old female suffered lateral and medial collateral ligament tears, diagnosed on ultrasound, in her ankle when she jumped down a height of 1 metre whilst distracted. She felt her ankle twist on both sides. Initial VAS was 9 out of 10 and ankle circumference 39 centimetres. She needed crutches to walk. Now, we've all had these horrendously injured ankles in our clinic. They are swollen and grotty for weeks. As soon as you try to increase loading, they react and they're just plain painful. You play the game of trying to increase range, strength, proprioception, etc. without irritating them and increasing pain and swelling. Well, this is where Mobiderm becomes your new tool in your arsenal. As this lady was lucky enough to be familiar with Mobiderm management of lymphedema and able to access Mobiderm the very next day, she decided to apply the Mobiderm using the bandaging technique. You can see on the photos, especially those on day 4, how the bruising has come to the surface where the Mobiderm squares have been. And what you don't get is that pooling edema still sitting in the leg above the tubergrip, which just moves back down into the ankle once the tubergrip's removed. This is due to Mobiderm stimulating the lymphatic system. Now, would you believe she was walking on it unaided within 3 days without any physio and fully weight bearing with no pain at about 2-week mark with an ankle circumference back to her normal 32 centimetres? I don't know about you, but that's not what I would have expected in this case, given what happened in the initial situation. Case study 2 is a client of mine with chronic lateral right ankle swelling, stemming back to a car accident she had 30 plus years ago. She sustained various lower limb fractures at the time. Unfortunately, she didn't want photos taken. She has undergone a lot of skin grafts, etc., but I'm very grateful for her permission to present her data. With this lady, I was actually treating her post her recent total knee replacement, but it was her chronic right ankle edema that seemed to be bothering her more. I don't know about you, but before Mobiderm, I doubt I would have had anything to offer in terms of managing this ankle edema. A 30-year history, extensive physio already, but because I had it, I took some baseline measurements. I taped her lateral ankle using the Mobiderm. When she returned 3 days later, she was overjoyed, and I was astounded. I really didn't believe that the Mobiderm could have that degree of effect. So, being the cynic I am, I didn't take it. She regressed over that next 4 days. Of course, we retaped the ankle and it did settle down again. In this third case study, my client came in 13 days after her total knee replacement, and she was really struggling with pain and poor sleep and confidence. Her range of movement wasn't too bad, but that did seem to be of no consolation to her. Of course, I went through the usual physio management relative to her, but I also added the Mobiderm 3-layer bandaging. Immediately, she felt a lot more supported and confident to exercise with the bandage in situ. She happily went home and returned to me 3 days later, enthusiastic, having slept far better and confident to tackle whatever rehab I was willing to send her way. From the table, you can see the objective results. Pain levels were much lower and she started gaining range of movement quicker and overall edema was coming down. For this lady, an additional week of Mobiderm was enough to minimise the obvious edema, and she continued a quick and successful rehabilitation back to her normal life and has shared her story of the Mobiderm with friends and family since. I'm now going to demonstrate the 3-layered bandaging technique I used on this last case study. You can transfer this same technique to a calf, hamstring, quadricep, etc., or a horribly sore ankle, like that first case, i.e. anywhere where you want edema control and you can bandage. The first layer protects the skin and it allows movement of the Mobiderm. In this case, we're using the cotton short stretch bandage. The second layer is the Mobiderm. In these larger areas, I use the bigger 15mm cubes. The final layer adds the compression. I'm using the biflexible non-adhesive bandage, which comes in both an 8cm and now a 10cm width. Since I'm bandaging, if I'm wanting to protect, I tape prior. Okay, I'm believing you're having trouble hearing. How are you going with the audio now? Okay, I believe you're having trouble hearing my audio on the video. I'm just going to try it once more, and then if it's not working, I will probably just talk you over the top of what's actually happening here. That's disappointing because it worked beautifully in the practice. So what I'm doing now is I'm just using the cotton short stretch bandage and working from basically mid-shin up to about mid-thigh. So with the application of the bandage, we're getting about a 50% overlap all the way up. So it doesn't matter if it isn't fully clear, or you've got a little bit extra in some parts, a little bit less than under, but you basically want a 50% overlap. So it just gives a really nice coverage, i.e. to protect the skin, and it also gives plenty of ability for it to move to enable the Mobiderm to do its job. I'm holding the 15ml Mobiderm there. This is actually a roll. It also comes in sheets. So we go directly over the cotton short stretch bandage. When we're applying it, you're not getting overlap now. You're essentially just trying to get a continuous roll. So it's a little bit awkward around the actual knee. If the knee's slightly bent, it's a little bit easier. So you're just wrapping it to get basically a continuous sheet of Mobiderm around the leg. So I sort of just tuck it in at the end there, just to sort of keep it relatively secure before I get my final layer. So this is the Bioflexible bandage I'm using here. In this case, I used an 8 centimetre. This is what I had in stock. If it was a bigger person, you would go for a 10 centimetre width. It's just easier. So the technique we use here is what I'm demonstrating. Here's a tug and then wrap. So what you do here is you tug it down, maintain the tension, and then wrap it around. So you'll see it again, there's a tug, and then you wrap. So again, you're getting a little bit of overlap of the bandage as you go, and you're trying to basically finish it at the end of where that Mobiderm concludes. And all I'm doing there is fixing it off with just the usual sort of bandage hooks. And what I'm demonstrating here is it moves really easily. So it's very easy and comfortable for the client to just move completely normal within the Mobiderm. As a general guide with bandaging, I do use that bigger 15mm Mobiderm across the bigger areas like knees or thighs or even the upper arms, elbows. Whereas I tend to use the smaller 5mm Mobiderm for feet, ankles, wrists, hands, and even in paediatrics. I'll now demonstrate another way I apply Mobiderm when I can't bandage. The taping technique still involves 3 layers and can be used across any joint you can tape, and bandaging isn't suitable. The first layer is a foam under it, which again protects the skin and allows the Mobiderm to move. The second layer is the Mobiderm. It's typically the smaller 5mm cubes, but I cut out a piece to cover the area of edema with a small margin around it. The third layer is the bypass tape, which is a unique compression tape and comes in both a 10cm and 3cm width. I'm now going to show you another video demonstrating the taping technique I've used for an acute inversion injury of the ankle. Now, if the foot or toes are also swollen, I would also tape the foot and any applicable toes first. You can see this in a video on the Mobiderm website under the training tab, and it's also part of another webinar in the series by Sarah Gear. She covers this in quite a great deal of depth. The taping technique is also suitable for wrists and hands in particular. Now, my normal individualised physio management doesn't change, and if I still want to tape to protect the joint, I do. I tend to just apply my sports tape over the top of the Mobiderm. Now, I'm going to bank we're probably going to have problems with the audio on this second video, so again, I'm just going to talk over the top of it. So I'll still run the video. So I'm doing the same introduction essentially I was just giving you before. So this is a fairly normal looking ankle, unfortunately, but that's what I had. So like most of you, you've probably used the high density foam horseshoe around the lateral malleolus to try and get a good deal of compression in the area, and I've had a lot of success with that over the years. Instead now, what I tend to do is cut out the Mobiderm to cover the same sort of area, or a bit bigger if there's more swelling, or a bit smaller if necessary. Now, the Mobiderm comes in a sheet, so what you can do is just cut out the section you need and just put the rest of the sheet aside. If you cut out small bits, just keep them aside. You can use them for smaller joints. So I just sort of have a bag of all my leftover Mobiderm thrown in that I can grab. So I'm just showing you how tiny and the arrangement of the Mobiderm. So the first step is obviously covering the area we're taping with the foam protection, so misted protection. I'm not shy in the volume of the foam I use. I want a really good coverage of the entire ankle and foot, anywhere I'm possibly going to put that tape. So right around the heel, down the foot, up the ankle. We don't want that bypass tape to attach to the skin directly. It really needs that protection. It just tears. It's really simple to use. It comes in a really long roll too, so it goes an awful long way. Now, I use the foam to also fix the Mobiderm in place, ready to tape. As you'll see here, I've covered the entire piece of Mobiderm. That's really handy if you're going to be using the same piece of Mobiderm on the same person, of course. You can't use it from person to person multiple times. I think it took me quite a few goes to do this video. That was the same piece of Mobiderm I used from the start. So this is the 10cm bypass tape I've got, and that's what I use first. What we're going to be doing is compressing across the lateral ankle, so right across that Mobiderm, going right round and leaving a gap of about 1 to 2 centimetres on the inside. So I'm measuring it out first, and with this, you cut it. So essentially I'll be using 2 pieces. So the second piece I was just explaining that I did slightly smaller. So I basically measured from halfway around the ankle in total. So to tear it or to open it, you sort of tear the backing paper and then pull it apart. You create 2 handles. So you just sort of turn it back on itself. And so you can see the herringbone pattern. This is the unique thing about this tape, is this pattern, and it helps create a huge amount of compression. So the place to tape on, I'm going from bottom to top. So I'm getting as much pressure as I can on the tape and wrapping it around. And then I pull my handle off the edge and fix it down. Now, if I've done too much and it's too long, I just trim it off. So about 2 centimetres gap on the inside there. You don't want to tourniquet the ankle, so that's why we have that gap. Again, see, just tear the top, pull it, it breaks, roll back your 2 handles. The backing paper can be a little bit of a pill, takes a bit of practice to get used to, but yeah, once you get used to it, it's pretty quick at doing this. Again, lots of compression on the tape, really stretch it out, place it on, and then wrap it around. And again, just making sure there's that 1 to 2 centimetre gap on the inside. I was just explaining, you trim it if it's too far. So I've now picked up the 3 centimetre bypass tape, and why I'm using this is to almost like picture frame around the outside of the edema and the Mobiderm. So it forms like a, it's like an outside barrier. And I tend to do probably 2 strips per section. So I'm going to come down the front, and then I'm going to go from there sort of across the bottom. So I've measured the length of down the front of the ankle only, because remember, the tape has a lot of stretching. So I've measured those 2. So break the top open, form a little bit of a handle down. So I'm feeling for where the Mobiderm is, coming straight down over its edge. Now the best bit about this tape, as you'll see, I can get my finger down the bottom of where that Mobiderm is, and I can actually turn that tape around the corner. So it turns around corners without creasing. So that's where it's got a huge advantage over a lot of your sports tapes, etc. So the second one, I'm going down the back of the Mobiderm this time. So fixing it in place, peeling back that backing paper again. Getting the compression on the tape, follow it right down. There's the corner, go around the corner and fix it. So that's the most basic version. And I'd probably do a second lot normally and I'd overlap by 50%. If you feel the need to do an anchor at the top, you can, but to be frank, I never really have felt the need. So from here, I would normally take the ankle at the top if I feel I need to. So my ankle, my usual 6s, my stirrups, heel locks, whatever's required. Look, the biggest advantage of bandaging over taping is you can reuse it. So if I've got a choice between taping and bandaging, I may choose to bandage instead. You can reuse and re-wash obviously the bandages, and you can wash the Mobiderm in warm soapy water. Obviously you don't use them between clients, but you can repeatedly use it for the same client. Another option is, especially with chronic edema, like that 30+ year history, would be an auto fit garment. which I'm going to introduce you to next. There are 2 lower leg AutoFit garments plus an upland garments available. This first one is the AutoFit stocking, which goes all the way to the groin. I recommend it for chronic edema, which affects not just the lower knee, but the knee and or the thigh, for knee surgery and especially total knee replacement surgery. The second one is the AutoFit sock. It finishes below the knee, and I'd recommend it for chronic edema in the foot and ankle, or lower limb, or for foot and ankle surgery. So why the garments? Because they are easier than bandaging for both the client and any other treating medical practitioner who may not be familiar with the product, especially if the client is having surgery. You measure key circumference points and length, and then just use the chart to find the correct size. If the client is between 2 sizes or very close to the bigger size, just go up a size. Then you can fit the garment to the client and teach them how to put it on and remove it, which is simply via Velcro tabs. So it's easy. There are non-slip dots on the bottom of the garment, and if the client is getting around without shoes, but you can slip a shoe or slip it over the top. They can be washed. You just follow the enclosed instructions. So having successfully used Mobiderm with acute injuries, chronic edema, and after total knee replacement surgery, I started thinking, was there any other application? I had this lovely 69-year-old female client who was working so hard on her prehab for a total knee replacement over the last 3 months, and persistent edema was still an issue. So why not use the Mobiderm prior to surgery, especially when there's edema present? If I use Mobiderm before surgery, surely we're removing excessive edema that is trapped in the tissues, making the limb and skin softer and easier to operate on. Surely it's firing up the lymphatic system to do its job and help recovery post-surgery. So I sat down and designed this protocol for using an AutoFit stocking for total knee replacement. You will have access to this later, so don't get lost in the detail. In short, if there's edema prior, just use the garment. If not, just use it post-surgery. Essentially, this same protocol could apply for any knee or foot and ankle surgery, but of course you would substitute the shorter AutoFit sock for foot and ankle surgery. My client was very interested, so I took the protocol, brochures, and some Mobiderm down to her orthopedic surgeon. He was very keen to try the garment as he didn't like TEDs and often felt that the tubey grip was useless. I ordered and fitted an AutoFit stocking to my lovely lady. Now, this is a busy table with lots of data, so I'll summarise the key observations. Initially, the instant drop in her circumference pre-op was surprising, as it had never changed in the entire time I'd seen her prior to the Mobiderm. You can see the difference in the 2 top photos. The first is before Mobiderm, the second is using Mobiderm for just 1 week and the day before her surgery. Post-surgery, she gained range twice as quick as I expected and dropped edema quicker than I anticipated based on my clinical experience. It's interesting to note that her pain went up a little, as did her circumference, when she returned to voluntary work, but this was definitely a little too quick at the 3.5-week mark. But she just said she felt so good. But she continued to gain range of movement. You can see from the photos that the leg by 6 weeks on the 24th of the 9th was looking good and it was functioning well. This is a photo of a 6-year-old male day 2 post his right total knee replacement. You can see the Mobiderm sitting under his leg. A 3-layer bandaging technique was used in this case, but the sheet of the 50ml Mobiderm rather than the 10 cm wide roll I demonstrated with. Have a look at the indentations of the Mobiderm and how the bruising has really come out, and note that for 2 days post-op, the leg really doesn't look that swollen. The consistent results we've seen when we've used Mobiderm with total knee replacement surgery are much improved pain, edema, quicker gains in active movement and strength, bruising coming out and resolving sooner, with the clients feeling a lot more comfortable and confident in completing their rehabilitation and returning to full function quicker. We've based our treatments of traumatic edema on research into Mobiderm and lymphedema. We are seeing amazing results in terms of pain and functional improvements with Mobiderm on individual examples of acute and chronic musculoskeletal edema and total knee replacement surgery. But we need some solid research into its application, including total knee replacement surgery, acute ankle injury, ankle and foot surgery, chronic musculoskeletal edema, etc. Do you want to be involved? But I think your first step would be to get your hands on the Mobiderm and have a go yourself. If you're like me, you do get those nasty, swollen, acute injuries, and then the other clients with that nagging, persistent edema. Until now, I really haven't been impressed with what I've had to assist them and enable a full rehabilitation to start and continue without flaring up. So, the main products you would look at having in your arsenal are the Mobiderm in a 5ml and 15ml in either sheets or rolls. The cotton short stretch bandages and the biflexidyl compression bandages to apply the Mobiderm in a bandaging technique. Bone under wrap, bypass tapes in both the 10cm and 3cm widths to apply the Mobiderm in a taping technique. The first protection layer and the top compression layers have been designed specifically to the Mobiderm. Do not substitute other tapes and bandages for them. Like everything, is there any contraindications? Of course. You don't use it on skin that's infected or very swollen, or thin skin where any compression may cause skin breakdown. And, of course, if there's any allergy to any of the components. So, head to mobiderm.com.au for access to additional resources, all the pricing, and even online ordering. As I mentioned earlier, there is a tab titled Training with a bunch of different videos by Sarah Gill, who's a lymphedema practitioner, explaining Mobiderm and how to use it. This webinar, along with the other 5 in this series, will also be on the website soon. If you have any additional questions, just contact Jenny from Medical Rehab via the contact details listed here. And in the future, here in Melbourne, we could organise a training session demonstration at your practice. And in the interim, or for our interstate viewers, there is a potential to run a video conference teaching session. So again, just shoot Jenny an email if this interests you. And just some lazy 26 references I use if you want to check them out. Before I answer any questions, I'd like to thank you on behalf of Thuasne, Medical Rehab, and myself for attending today's webinar, Mobiderm and Musculoskeletal Trauma. Personally, I'd also like to thank Jenny, Sarah, and Alan for all your help putting this together. If you have further questions once this presentation is finished, or just don't get to your question, feel free to send them through to info@medicalrehab.com.au. I'll go through any questions now. Okay, so the first question I've got here is, does the pressure of the bandaging vary dependent on the severity of the injury concerned, acute or chronic injury? To be frank, at this point in time, I've just kept a very even sort of compression. The garments are about 15 to 18 milligrams of mercury. I suppose you look at it from where we've come from with compressing. You always use a firm technique, but not a technique to cause so much restriction of blood flow into the foot or the hand, etc., that you impair. So I'd be just using a consistent firm technique through. and it's more, the compression has a huge effect, don't get me wrong, but it's the actual Mobiderm, it's that pressure differential, and it's the movement, and it's how it moves the skin and mobilises the lymphatic system that probably is its big advantage over traditional compression. So it's not about ramming huge amount of compression on a musculoskeletal, whether it's acute or chronic injury. It's about the overall practice. 3-layer bandaging, yeah, is also 15 to 18 mil. So same sort of pressure there. So just trying to see the next one. Okay, so question regarding ankle. You don't get crawling of the forefoot when you take only the ankle, the Mobiderm, and the bypass. If so, how do you fix that? So if you've got swelling into that forefoot, you'd be taking that first. So as I said on the website, Sarah's already got a fantastic video on taking the foot, and she's also done another webinar this series where it's in great detail how you take the foot. So if there's swelling there, absolutely. If you're not getting that cooling down already, and you've used that technique of picture frame around the bottom of the Mobiderm. So if you think about if your swelling's in this area, and I've got the Mobiderm to here, and then I'm taking below that Mobiderm, so on the ankle, you're already sort of holding that swelling up, hopefully, and it shouldn't be cooling down. That's sort of the point of using that sort of picture frame sort of technique. So, but if you are concerned that there is some edema coming into the foot, I'd be taking the foot. So you can take the foot, you can take the toes. Cool. Do you leave the TED stocking on underneath the orthopedic garment? I had a discussion with the surgeon that we're doing the toe knee replacement, and he didn't want to use TEDs at all. But my belief is that you theoretically can. TED stockings, if I remember, I did write this down somewhere, have a variation of pressure. So they're 18 milligrams of mercury at the ankle, 14 at the calf, 8 at the popliteal, 10 milligrams at the lower thigh, and 8 at the upper. So if you're looking at the Mobiderm garment, which, as I sort of said, is between 15 and 18, so it basically covers the same pressures that a TED does. Do you need the TED or not? And you possibly just, if a surgeon really wants the TED stocking, theoretically, you can use it. But do you really need it when you're also already covering the same amount of pressure through the lymphatic system? Good question. This is where we need some more research. But there's theoretically nothing saying you can't. We had that discussion at the start. So I said, well, you could put your TED underneath. But as I sort of said, the surgeon I was dealing with initially with this was very anti-TEDs anyway. I've just started another case. I'm just waiting to talk to the surgeon. So I'll be very intrigued to hear his view on it too. So I think if the surgeon's adamant they have to be in TEDs, fine. If they don't have to be in TEDs, go with the Mobiderm. So that's where I probably sit at the moment. We don't know. We need more concrete research saying either way. So do you advise them to keep it completely dry? How many days would you leave the taping on the ankle for? So the ankle taping is probably 3 to 5 days, and ideally, yeah, you would keep it dry in that time. And that can be the advantage of using the bandaging, because of course you can remove the bandage and you can then place it back on. But yeah, I've kept mine all dry, and as I said, up to about 5 days, it can stay on quite nicely. I'm not seeing any more crop up yet. Just a comment, even when edema before total knee replacement, is it likely to speed up the healing afterwards? Good question. It's a personal opinion. I think I think if you've got sort of a process going on in the knee, we know that sometimes you can have edema present and we can't always see it. So could it help? I suspect it possibly can. I suppose it's about looking at compliance. So if the client obviously sees there's edema prior and they see the results with it, the lady I've just fitted a garment to is having a knee replacement next Friday. So I'm disappointed I couldn't actually bring her data onto this. Her knee's horribly swollen at the moment, and she had it on for one night and messaged me and said, "Oh my God, my knee feels so much better." In Q, basically. So if the client's happy to wear it prior and they don't have obvious edema, would I get them to wear it? Absolutely. So I do believe that if you're firing up the lymphatic system, you're enabling it to work optimally into that post-op period. Surely you're going to get a better outcome. How many days can the patient safely keep the 3 bandages? Theoretically, you can keep it on sort of ongoing. I bandaged my lady. She left it on, I think, for a full 48 hours, and then her husband had a bit of a go. At the end of the day, because we're only using the 3 layers, and if you're not putting a huge amount, you're not going to overcompress very, very, very easily. So they're not going to, someone else bandaging probably not going to have the nice tug and wrap technique that ideally gives us the best results in the ideal compression. It'll have less compression, but will it have some effect? Yeah, it will. So yeah, so you can repeatedly bandage ongoing. But that's where I think the auto-fit garments come in. So rather than trying to get someone who maybe doesn't really, is not comfortable, or the other half's not comfortable bandaging, you can use the auto-fit garment if it's more of an ongoing thing. Cool. Fantastic. Well, that looks like we're finished. There's no more questions. So once again, thanks again for sitting in on today's webinar. The recording will be made available to you, so keep an eye out on the Mobiderm website. And I thank you for your attendance.